Welcome to Public Health America, a weekly program produced by BronxNet in partnership with Mercy College. I'm your host, Dr. William Latimer. Here on Public Health America, we speak with experts from an array of specialties across the liberal arts and health professions to provide you with not only the best science, but practical tips to live a healthier life. We also celebrate what studies have long documented, namely the unparalleled value of a liberal arts college education by setting the stage to pursue a career of your choice, increase lifetime earnings, and engage in civil debate. Our experts will share decisions they made and support they received that helped them to beat the odds. By sharing one or two life lessons, their stories may provide you with the inspiration and method to realize your dreams. This is Public Health America. Welcome to Public Health America. I'm your host, Dr. William Latimer. It's my pleasure to welcome today Dr. Joseph Amen, clinical professor and director of the Office of Global Health at Drexel University. Joe, welcome.
Thank you very much. It's a pleasure to be here.
Thanks so much. My pleasure. So I know you've been doing some cutting edge work through the Office of Global Health on health and human rights. Tell us a little bit about your work.
So health and human rights is really about how governments have certain obligations to respect, protect, and fulfill the right to health for populations. And there are a lot of issues around health equity, around which populations have access to health care, but also the social determinants of health, the things that influence whether you're able to be healthy. And that can include education, the environment. It can include how police function and criminalize certain populations or certain behaviors. And one of the big projects that we have going on right now is a 20-country study funded by the Global Fund Against HIV, TB, and Malaria that looks at whether rights-based interventions can increase the ability of certain populations at risk for HIV and TB especially to access care and to stay in care.
That's great. So I did about 10, 12 years of NIH-funded research in South Africa around before antiretrovirals had really come online. What are some of the countries that are involved in this study?
So there's a number of countries in Africa, Kenya, Senegal, Sierra Leone, Cote d'Ivoire. There's countries in Latin America like Honduras, in Asia, the Philippines, Indonesia. It's really countries that have a lot of issues around HIV and trying to get more people into care and into prevention services.
So tell us a little bit about, you had said when you were describing that study, it seemed like you were laying out what it is you were trying to test, change, and what the outcomes were. Why don't you define that for us in a little bit more detail?
Yeah, well, I mean, there's been a long history and effort of trying to increase access to antiretroviral drugs and TB treatment to sustain people once they're on it. And what we've seen is that it works for some populations, but other populations struggle. They struggle getting into care. They face discrimination in healthcare settings. They face barriers because the police interrupt their attempts to access harm reduction for, to use for drugs, substance abuse issues. And so what we're trying to look at is things that aren't conventional public health programs, things like using paralegals to negotiate access to care and to try and facilitate and decrease the barriers that these populations face. There's other aspects of the interventions that are being funded too, like training healthcare workers to not discriminate against certain populations. And this isn't just an issue for HIV and TB. It's also commonly seen for adolescent girls and young women, for example, seeking access to reproductive health care, where they're maybe turned away entirely, or they're just treated poorly when they seek help.
So access to care, training of healthcare workers, that it sounds like that's two major foci of this larger 20 country study. Is that close to right?
That is. And there are other elements of it too that involve things like addressing stigma. Stigma is a big problem with certain diseases and the populations that are perceived to be at risk for them. And so how do you effectively try and reduce societal stigma and societal discrimination? And so that's another component of it as well.
And you said your two main outcomes, disease-wise, is HIV and TB?
We also are looking at malaria, but not in all 20 countries. And
okay.
When we look at malaria, we're really looking at populations like migrants and refugees that may be turned away from care or have trouble getting access to care. So that's a particular aspect of the project as well.
Got it. So 20 countries, that's obviously a fairly big study. What is there variability in the vector of transmission of HIV and or TB in these countries, e.g. Injection drug use versus sexual transmission?
Definitely. There's big differences from country to country. One country that we're working on actually is Ukraine. And Ukraine is a challenging place to work right now. We're working with local partners. We're trying to understand how, the epidemic of HIV and also of TB to a large extent is centered around people who use drugs. And we're looking to see how the conflict that's going on now, the Russian invasion and war, has led to displacement of populations and how they can better get reintegrated into care. And it's really inspiring what the Ukrainians and the Ukrainian Public Health Institute have been able to do to ensure that these programs are able to continue to find people and to engage them in both HIV treatment, TB treatment, but also harm reduction treatment.
Mm-hmm. So are there differences in the study's approach to assisting vulnerable populations or stigmatized populations to have access to care based on the vector of transmission, or is it sort of one size fits all?
There's an element where things like paralegals can engage on whatever the issue is, whether it's reproductive health care, whether it's HIV, whether it's TB, whether it's malaria. And what I find really interesting about this, I trained as a parasitologist, as an epidemiologist, but there's limits to how successful those approaches have been. And so this is a really kind of attempt to be out of the box and to find the populations that are being left behind. And we're not going to end the AIDS epidemic. We're not going to end TB or drug-resistant TB epidemics unless we're able to reach everyone. And we need to try new things, and then we need to study them and determine how effective they are, how we can improve their effectiveness, how we can scale them up to really make sure that everyone has equal access to care, that their right to health is respected.
Let me ask you this. When antiretrovirals improved, not came on the scene, but when they got to a point where in a country like the United States, if you had, and feel free to revise or challenge anything I'm saying, that if you had access to care, adequate access to care, that HIV, which once very clearly was a death sentence, is now viewed as a chronic disease. Obviously, we still have many countries, and I would imagine that the 20 you're working with all are in this category, that there are still hundreds of thousands and possibly millions of people in a country that have HIV, that have TB, that don't have access to care, and that HIV is still a death sentence. My question is this: has there been a shift in, if you will, the global approach to HIV prevention and treatment that is hurting the initiative, because under the best of circumstances, it is now viewed as a chronic disease as opposed to a death sentence?
That's a great question. I don't think it's quite like that. I think that there's still a lot of commitment. There was just an anniversary around the start of PEPFAR, the U.S. main HIV program. And people are still very dedicated to ensuring that antiretroviral drugs, which are very affordable right now, are really available and can address, this issue in countries around the world. We definitely have problems with intellectual property rights around medicines, and we saw that with the COVID vaccine. But the commitment to HIV is still very strong, and the commitment to TB, which really became worse during the COVID pandemic as people weren't able to access care, is still strong as well. And the Global Fund is really a leader in that effort too.
Great. So with just a minute or so left in this segment, this part of the program, what is your 3 to 5 year goal? What would you like to see in terms of really moving the needle in terms of this global study with 20 countries?
Well, I really think we've seen already the effectiveness of some of these programs. I think there needs to be more understanding of how these programs work and can integrate into traditional public health and HIV and TB programs. And then we need to see the commitment to scale them up. And, it's challenging sometimes to say we're going to use paralegals to confront police as a public health strategy. That's something that people aren't familiar with. But I think that, to me, is the phase that we're going into with this research.
Sure. Sounds good. We're going to take a quick break. When we come back, Dr. Amen is going to tell us a little bit about his undergraduate experience and how his education provided the basis for him to have this exceptional career and profession in public health. This is Public Health America. I'm your host, Dr. William Latimer. We'll be right back.
You can now watch MNN, Brick TV, QPTV, and SIC TV on BronxNet. Tune in to BX Omni, Channel 67 Optimum, 2133 Fios during most Sunday evenings. We'll show you some amazing content from our friends at Manhattan Neighborhood Network, Brick TV in Brooklyn, Queens Public Television, and Staten Island Community Television. Every borough represented in the Boogie Down. Epic partnerships for the ages. And catch our new Next channel, produced in partnership with MNN, 24/7 on BronxNet Channel 952 Optimum and 2138 Fios.
Even though we didn't grow up together, he's my favorite brother.
Hey, sis.
I'm the baby of the family, and he's the gentle giant.
What you know about Port Georgia?
Man, please, that's a classic.
You know when they say people are a rare breed? Yeah, he's that.
I'm sorry, I'll be back in a few hours.
Don't worry, Shug. You know I'm for you.
I know.
Go get the football.
That was my favorite memory. He was always for ya. This is a true story of me, Bridget Floyd, and this guy, George Perry Floyd Jr., my big brother.
You can talk to me if you're feeling sad.
Thanks for hearing me out, bro.
Whenever you need to talk, I'm here, okay?
How do you know when you've made the right decision? It's the feeling you get in your gut. The one that tells you what's right or wrong. It's the one that says, sure, I can have a drink. Or the feeling that says, okay, I've been drinking. Now what? It's the voice inside you that says, I'm buzzed. Better leave the car when it's time to go. Plan ahead. Catch a sober ride. Buzz driving is drunk driving.
Welcome back to Public Health America. I'm your host, Dr. William Latimer. Joe, at the beginning of this part of the segment, I always ask the exact same question of guests. Where were you born, and what were some of your formative experiences?
So I was born in Western Massachusetts, but I really grew up in New Jersey. And I think one of the most formative experiences I had was in high school. I was an exchange student in Bangkok, Thailand. And that was a really eye-opening experience to go to school in Bangkok in a language I didn't speak, and to meet people who were growing up in a very different place than I did. And that really, I think, sparked my interest in global health and being interested in traveling. I went to college back in Western Massachusetts, and I really wasn't sure what I wanted to study. I studied economics. I studied a little bit of anthropology. I kind of got interested in medical geography, and all of it sort of started crystallizing a bit around the area of public health. Even though I wasn't exactly sure what it meant, there were also a couple of books that really influenced me. One was And the Band Played On, which was about the onset of the HIV epidemic in the United States. And the other was a book called Rats, Lice, and History, which was a kind of very entertaining book about the discovery of typhus. And these two books about how public health were done really drove me to think about graduate school following my undergraduate education.
That's great. And you know, the experience you had at a relatively young age to be able to go to another culture, another country, another educational system, you know, I mean, it's you can't. There's no way to value that. It's invaluable, and clearly you make that very clear. So tell us where you went to undergrad. What was some of the decision making that went in to choosing where you went, and what was that experience like?
So I went to school at Hampshire College in Amherst, Mass. And Hampshire has a very unique curriculum. There's no grades. People are given evaluations for their courses. They design interdisciplinary majors, and that really spoke to me as a student coming out of high school. I did pretty well in high school, but I also felt that there was a lot more that I wanted to learn that was kind of not in one course or the other. And so the idea of going to a school where you could kind of create your own major and think about what you wanted to do and pursue it, and have responsibility for that was really appealing to me.
That's great. And what did you formulate your own undergraduate major, or what was your major?
So I started really with this focus on economics and economic development. But the more I studied it, the more I thought that what was most interesting about it was social development and sort of the countries where, even though they were extremely poor, had good results in terms of child survival and in terms of life expectancy. And so why were some countries that were poor able to do that, and why were some countries that were poor not able to do that? And a lot of it came down to things like maternal literacy. And so I was really curious about sort of how do you think about building public health and building improved social development in countries that didn't have a lot of resources.
That's fascinating, and that itself would be worthy of a complete segment of discussion. Were there challenges that you faced, either getting to college or just unexpected bumps in the road that you faced?
You know, I think that everyone has challenges, and I certainly had challenges in terms of, some of the classes that I had were really tough. I had challenges in terms of not being sure what I wanted to do. I took some time off in college, just when I was starting to think about public health, and I ended up doing an internship with an organization working with farm workers. And that was an opportunity to get out of the school environment and really see what was happening on the ground and sort of think about the career that I wanted to pursue.
So another really good shout out, if you will, to experiential learning. You know, taking time off, getting out of the classroom, and actually doing boots on the ground kinds of experiences that then can inform and go back into your academic learning and make both better. So when you graduated from Hampshire, what was your degree in?
So it was an interdisciplinary degree, and the title of it was basically economic development and public health. And I went from there and did a master's in public health at Tulane University in New Orleans.
Great school. What'd you do at Tulane?
Well, it was interesting because I wasn't sure, but I kind of wanted to get a little bit more into science. I had done a lot of social science and I wanted to get into more science. And I went into a program that combined a master's degree with 2 years in the Peace Corps. And so you did a year of coursework, and then you did 2 years in the Peace Corps, and then you got your degree. And so the focus of my master's degree was in parasitology, looking at tropical diseases and parasites. And then the 2 years I spent in the Peace Corps was working on guinea worm eradication, which is a disease that is now on the brink of worldwide elimination. There's fewer than a dozen cases reported in the last year.
And where did you might have said this, where did you do your Peace Corps work?
I did it in Togo in West Africa.
Got it. What a great experience. A really amazing journey of, international experiences and then traditional, academic experiences in the U.S. Talk a little bit about that synergy, because clearly you, whether through serendipity or deliberate action, have had multiple moments in your life where you sort of integrated or gravitated to both of those kinds of things: traditional education in the United States and then international education. Talk about that sort of duality.
Sure. So that's definitely a thread line throughout my career. I worked, with farm workers in California. I worked also with the Centers for Disease Control on disease outbreaks in the U.S. But I've always been drawn to the international work, and to me, it's about the fact that we live in a global society and that diseases cross border, people cross border, and we can't look at things just in one place or another. And I've learned so much in all of those different environments. There are people that have, mentored me, who've taught me formally in classrooms or informally, when I've been working somewhere. And understanding cultures is also really critically important in public health. You have to understand, how you interact with different populations and how messages are heard, even if they're not intended in the way that you say them, and how you develop real strong partnerships across, countries, across people, and have that as the strength and the ability to get work done.
Absolutely. And clearly you've taken that experience in your education and your experiential learning locally and abroad into your career. What did you do? So you got your MPH and you did Peace Corps. What was the next step?
So the next step was working in HIV internationally. I worked for 3 years in Washington for a project that was funded by USAID. And it was kind of at the start of the HIV epidemic being really recognized. And when I was in Togo, I started to see a few cases of HIV. And it was a time that people didn't understand what it was. There was a time when there was a lot of stigma. And I came back and really wanted to be dedicated to that, that focus. And so I worked there for 3 years before going on to get my PhD. And for my PhD, I went to the Uniformed Services University of the Health Sciences in Bethesda and focused again on parasitology and worked specifically on malaria as my main focus of my dissertation.
So that in Bethesda, that's where you got your PhD? Is that what you're saying?
That's right, yeah.
And what was the institution again? I'm sorry.
The Uniformed Services University of the Health Sciences. So it's the military's medical school and graduate school for biomedical sciences.
Great. And then so that was a PhD, or what was that?
Yeah, that was a PhD, and it's on the same campus as Walter Reed and the Naval Institutes, and across from the National Institutes of Health.
Excellent. Well, that's a nice location.
It was a great location and incredible research being done. And the focus of it really was to better understand these diseases and be able to protect people from it. So it was a really great experience.
So let me ask you this. I mean, in our lifetimes, whether it's HIV, malaria, I mean, for goodness sake, TB's been around forever, right? I mean, when was the first case of TB? I don't even know. And I'm sure you could tell us. The pandemic, with COVID-19, literally changing the world. And now there isn't a person that doesn't know what epidemiology is, whereas before everybody thought it was dentistry. And now we know what that is. Clearly we can point to successes. We can point, over a decades long trajectory that things like antiretrovirals were developed, that things like vaccine were developed, and that made an infectious disease like HIV a chronic disease if managed correctly, and or sequelae associated with COVID-19 far less life-threatening if you do 2 vaccines and, a booster every 6 months. What do we, and if this is not a fair question, just tell me and we'll move on. When do we get to eradicate TB? Like what's the we don't have this anymore plan? Is that part of the discussion, or is it just risk reduction?
So, I think that what you're raising is a really, really interesting topic, which is almost kind of, is there a limit to, depending upon technology and science, to end the diseases that we face, right? We have effective drugs for TB. We have effective drugs for HIV. But there's another element to it. And the element to it is reaching more people that aren't being reached, and improving housing conditions, and improving nutrition, and improving knowledge and understanding of how diseases get transmitted. I was shocked in Togo as a Peace Corps volunteer how many people didn't know where malaria came from. And you can't protect yourself from malaria if you don't know where it comes from. And so there's an element where we have to, if we're going to aspire to really make an impact, we have to think about both sides of that. We have to think about the side of the technology, but we also have to think of the side of working with people, improving, drainage so that mosquitoes aren't reproducing, improving knowledge and in classrooms, and getting people to know where they can go for care and quick treatment so that they don't become a source of further infection.
Excellent. I want to thank Dr. Amen for joining us today on Public Health America. I want to thank our viewers for tuning in. This is Public Health America. I'm your host, Dr. William Latimer. See you next time. Until then, take care.